A decrease in hemoglobin level is called anemia, and if anemia occurs due to iron deficiency, it is called iron deficiency anemia. The normal level of hemoglobin is different for males and females. Males 13.5 to 17.5 and females 11.5 to 13.5 grams per deciliter. Iron daily intake is 15 to 20 milligram per day, but only 10% of this is absorbed. Iron absorption is increased to 20 to 30% in iron deficiency anemia and pregnancy. Iron deficiency anemia is the most common cause of anemia in the world. Most of the iron is in the ferric form, which is not absorbed. Most heme iron is absorbed in the proximal intestine. Intestinal heme transporter is called HCP1 and is mostly present in the duodenum. Non-heme iron is mostly absorbed in the duodenum. Ferric form is converted to ferrous form by ferrireductase and thus absorbed. Iron is absorbed at the tips of villi by cells which adjust iron absorption according to the body needs. DMT1 is the protein which transfers iron across the mucosal cells in the small intestine. Iron is stored as ferritin. So that's why it is important to measure the serum iron as well as the serum ferritin for iron deficiency anemia. The transporter protein FPN1 or ferroprotein 1 transports iron. Hepcidin is the molecule which regulates the iron absorption. If hepcidin is high, iron absorption is low, and if hepcidin is low, iron absorption is high. Normal serum level of iron is 13 to 32 micromole per liter. Iron levels are more in the morning. In the plasma, it is the transferrin which transports iron. Now we come to the symptoms of iron deficiency anemia. The symptoms. As far as the main generalized symptoms of iron deficiency anemia are concerned, they are same as for any other anemia. For example, fatigue, lethargy, headache, unable to concentrate, faintness, breathlessness, angina, palpitations, hair loss, intermittent claudication, and dysphagia due to esophageal web in Plummer-Vinson syndrome, brittle nails and chironychia, and grumpiness, which means irritability, and crotchetiness, which also means irritability, and crankiness, which also means irritability. Now, there are four main causes of iron deficiency anemia, and topmost is blood loss, increased demand, for example, pregnancy or growth. Number three, decreased absorption, for example, post gastrectomy. And number four is poor intake. Most of the iron deficiency anemias are due to blood loss. Then, premenopausal women are at risk of iron deficiency anemia due to menstruation. Hookworm is a common cause of iron deficiency anemia worldwide. For unexplained iron deficiency anemia, hookworm must be kept in mind. Poor diet, just comprising of vegetables and devoid of meats, is also a major cause of iron deficiency anemia. So, if a patient comes, we have to ask, does he take meats or not? Because avoiding meats like red meats, liver, chicken, fish is a major cause of iron deficiency anemia. Even in developed countries, infants are at high risk of iron deficiency anemia, and particularly premature infants, the iron deficiency anemia is more prevalent. What are the signs of iron deficiency anemia? Now, as far as the signs of iron deficiency anemia are concerned, they include pallor, tachycardia, systolic murmur, glossitis, cardiac failure in severe cases, chylonychia, brittle nails. Chylonychia is spoon-shaped nails which occurs in chronic iron deficiency anemia. Atrophy of the tongue papillae can occur in iron deficiency anemia. Hair fall can also occur in iron deficiency anemia. Angular stomatitis can also occur in iron deficiency anemia. Iron deficiency anemia with glossitis and dysphagia is called Plummer-Vinson syndrome. So, what is Plummer-Vinson syndrome? Three things: iron deficiency anemia, glossitis, and dysphagia. Diagnosis. Diagnosis of iron deficiency anemia relies upon clinical history as well. History should comprise diet intake, presence of blood in feces, or use of drugs like NSAIDs. NSAIDs can cause GIT bleeding. Blood in the feces can be due to hemorrhoids or colonic cancer, etc. In women, ask about duration of periods, presence of clots, and number of towels used to ascertain the gravity of iron deficiency anemia. Now we will talk about iron absorption. Heme iron is absorbed better than non-heme iron, that is, iron from meats is superior. Ferrous iron is absorbed better than ferric form. Gastric acidity helps to keep the iron in ferrous form, hence more absorbable. So, taking oranges and citrus family fruits will help in the absorption of iron. Iron absorption is increased when iron stores are low. In bleeding, also, iron absorption is increased. Iron absorption is more at high altitude. When iron overload, when iron overload, iron absorption is decreased, except in hereditary hemochromatosis. In hereditary hemochromatosis, iron absorption is increased. In an adult male, 20 milligram of iron obtained from red cell breakdown is utilized again in the body. About two-thirds of total iron is in the circulation as hemoglobin. Total iron as hemoglobin is 2.5 to 3 grams in an adult male. Iron is stored in reticuloendothelial system, hepatocytes, and skeletal muscles. Total amount of iron stored is half gram to 1.5 grams only. This does not include the iron of hemoglobin. Two-thirds of iron is stored as ferritin. One-third of iron is stored as hemosiderin. Small amounts of iron are also found in plasma and some more in myoglobin and enzymes. As mentioned earlier, heme iron, for example, the iron obtained from fish, meat, liver, enzymes, is absorbed better than non-heme iron sources. Ferritin is more easily mobilized than hemosiderin, and hemosiderin is found in macrophages, in bone marrow, liver, and spleen. Every day, zero point 0.5 to 1 milligram of iron is lost in feces, urine, and sweat. Menstruating women lose 30 to 40 ml of blood per month, an average of zero point 0.5 to zero point 0.7 milligram of iron per day. Blood loss of more than 100 ml will cause iron deficiency because simple iron absorption from the gut is not enough. So 100 ml loss of blood is going to cause iron deficiency anemia. Iron demand also increases during growth and pregnancy. Increase in iron content is called hemochromatosis. In hereditary hemochromatosis, HFE gene causes increased iron absorption. Secondary hemochromatosis is due to iron overload in conditions treated by blood transfusion. Do not take iron with milk or calcium as it decreases the absorption of iron. But if you take it with vitamin C or so things or fruits with having high content of vitamin C, the absorption of iron will increase. Now, what is the appearance on CBC? On CBC or complete blood count, it shows microcytic hypochromic RBCs. So iron deficiency anemia is actually microcytic hypochromic anemia. The RBCs may show poikilocytosis, which is variation in shape, and anisocytosis, which is variation in size. Serum iron falls in iron deficiency anemia, but iron binding capacity increases. So iron binding capacity is going to increase. If transferrin saturation is less than 19%, iron deficiency anemia is present. Serum ferritin level shows amount of stored iron. Normal value of serum ferritin is 30 to 300 microgram per liter in males and 50 to 200 microgram per liter in females. So the normal level of ferritin is 30 to 300 microgram in males and 50 to 200 microgram per liter in females. In iron deficiency anemia, low serum ferritin indicates iron deficiency anemia. Ferritin level can be falsely high in inflammatory or malignant diseases as ferritin is an acute phase reactant. In case of liver damage also ferritin level is increased. In hepatitis and a rare disease, hemophagocytic lymphohistiocytosis, ferritin can be very high. The number of transferrin receptors increases in iron deficiency anemia. GIT examination and investigations could be needed to rule out bleeding as a cause of iron deficiency anemia. Whereas microcytic and hypochromic picture, which occurs in iron deficiency anemia, it can be present in other diseases also, like thalassemia, sideroblastic anemia, and anemia of chronic diseases. Next, we come to the treatment of iron deficiency anemia. Best treatment is to first rule out the cause of the iron deficiency and then treat it. Patients of iron deficiency anemia who take iron can increase their hemoglobin level by 1 gram per week per liter. In most cases, oral iron is enough. Best iron preparation is ferrous sulfate 200 milligram TID or 3 times daily. So as we mentioned that if a person takes iron like ferrous sulfate 3 times or even 2 times, he will increase his hemoglobin by 1 gram per week. Iron tablets should be taken on empty stomach as they are then best absorbed. So on empty stomach they are best absorbed. If patient responds with side effects of nausea and vomiting, etc., the dose can be reduced or ferrous gluconate 300 milligram twice daily can be given. Also, patient may take it with food because then it's a problem. Patient is having GIT symptoms, so he cannot take on empty stomach. So give it with the food, and also change to ferrous gluconate 300 milligram twice daily. Usually, people are non-compliant, so one has to take care that the patient is compliant with the medicine and is taking medicines regularly because it is to be on extended period of time. So many of the patients they do not abide by the regular routine and they miss their doses. Oral iron therapy should be continued for approximately 6 months to replenish the iron stores and to increase the hemoglobin level. If despite oral intake patient does not improve Then the cause may be non-compliance or hemorrhage or thalassemia trait. Now, what are the indications of parenteral iron or iron drips or iron by IV route? So they are required if there is no improvement by oral iron therapy, and if there is severe anemia, and if there is presence of severe malabsorption, and if there is intolerance to oral iron, and if there are chronic diseases like inflammatory bowel disease. So in these cases, one has to resort to the parenteral iron therapy. Parenteral iron is given by slow drip of low molecular weight dextran or iron sucrose or ferric carboxymaltose or iron maltoside. Before giving iron IV, allergic test must be done. There is more iron in ferrous sulfate form than ferrous fumarate as mentioned earlier. Now, what are the best sources of iron, dietary iron? That there are two groups, heme and non-heme. Heme iron sources are the best one is liver, and then red meat, which is cow meat or buffalo meat or sheep, and then shrimps, then fish, then turkey, and lastly chicken. And egg yolk is also a good source of iron. So the people uh, who are having iron deficiency anemia, they should take at least one egg per day. And remember, turkey has more iron than chicken. In fruits and vegetables, spinach has maximum iron, but apart from that other sources of non-heme iron are chocolates, broccoli, legumes, raisins, mushrooms, nuts, dates, figs, peas, beans, macadamia, almonds, and pistachio seeds. They are all good sources of iron. Vitamin C helps in absorption of iron. So the take home message is that the best source of iron is liver, then red meats, then fish, and then eggs. And along with this, of course, shrimps and turkey and chicken.